Good morning, everybody. So today I'm going to talk about a new molecule and a new way or a new treatment strategy in depression. So today we are going to talk about oral glutamate modulator. So we will be dealing with this topic first by talking about depression, the current available treatment options, the unmet medical needs, introduction about the today's molecule, its mechanism of action, dosing, some trials, safety data, and salient features. So we all know that depression is a major public health concern. It causes a lot of suffering, dysfunction, comorbidities, causes a lot of economic burden also. It is the second leading cause of disability adjusted life years according to WHO. And looking at the Indian perspective, the prevalence is 7.6%. In females, it is higher, 8.1. In males, 7%. In elderly, also, it is 8%. It accounts for 87% of suicide. And higher risk of suicidality is seen in patients with major depressive disorder. And compared to others, the risk is lower, but in depression, the risk is quite high. And we all know about these drugs, the current available treatment options. So we have SSRIs like fluoxetine, sertraline, escitalopram, SNRIs like venlafaxine, duloxetine, desvenlafaxine. We have serotonin modulators like trazodone, vilazodone, some atypical antidepressants like bupropion, mirtazapine. Older drugs which are less commonly used, which are tricyclic antidepressants like amitriptyline, imipramine, and MAO inhibitors like trancyclomine and siligeline. So what are the unmet needs? Whatever treatment options we have, even after that, only two-thirds of patients fail to remit after the initial treatment with SSRIs. Approximately two-thirds fail to remit after switching to a different antidepressant. And these patients often experience week-long delays. So even if there is improvement, there is a lot of delay in improvement to be seen. And side effects are also seen in most drugs like weight gain, sedation, abuse potential is also seen in some. So that is why we are going to talk about today's molecule, that is dextromethorphan plus bupropion combination. So why is this combination used? So bupropion, as you can see, it competitively inhibits cytochrome P enzyme, so CYP2D6. If we give bupropion along with dextromethorphan, what it is going to do is inhibit the metabolism of dextromethorphan. So bupropion component serves to increase the plasma levels by inhibiting its metabolism. So about the molecule, it contains two components that we have seen, dextromethorphan and bupropion. It is bilayered, orally administered. Current indication is only for treatment of major depressive disorder in adults. Usually absorption occurs within 3 hours with Tmax of 2 hours. Food does not affect it, so it can be given either with food or without food. Steady state is seen in 8 days. Half-life of dextromethorphan is 22 hours. Bupropion is 15 hours. That's why we need to give the extended release form of bupropion. Excretion, both of these are excreted mainly through the urine. Now, mechanism of action. So, dextromethorphan is a antagonist of NMDA receptors. So, currently a lot of focus is on NMDA receptors. Most of the new drugs are focusing on NMDA only. So, what is happening if NMDA receptors are getting antagonized? This antagonism leads to alteration in the inhibitory tone of interneurons and having a direct effect on the postsynaptic NMDA neurons also. We'll see what these does in the long run. it also acts on sigma 1 receptor. So it's a sigma 1 receptor agonist. And bupropion, this increases the plasma level of dextromethorphan. Along with that, it is also inhibitor of neuronal reuptake of norepinephrine and dopamine. So norepinephrine dopamine will be increased in the synaptic cleft. So as you can see in this diagram, we'll go from lower to upper. So first, see at the yellow portion. So the dextromethorphan, it is acting at three places. One, presynaptically, it is inhibiting the inhibitory neurons on the NMDA receptor. Then it is acting on sigma 1, and then it is postsynaptically acting on NMDA again. So by acting on sigma 1, again we are increasing the glutamate and monoamine receptors. So if glutamate and monoamine are increased, again the neurotransmitters will be increased and it will help in treatment of depression. So this is basically the mechanism of action at the synaptic level. Coming to the dosing, so for the first 4 days, it is given once a day. So one dosage strength is recommended by day 4. So once a day we are giving in the morning. From fourth day, one tablet is given twice daily. The strength is the same, so it comes in only one strength, and patient is said not to take more than 2 tablets within 24 hours. So in one day, twice daily is the maximum dose. In special population, if there is hepatic impairment, so with child POG score A to B, the dosing is same. So initially once a day for 3 days and then twice a day. If there is a child POG C score, then it is not recommended. So you're not supposed to give this. Again, with renal impairment also, we check the GFR. If the GFR is between 30 to 60, we give it daily and only daily. We do not shift it to BD. If the GFR is less than 30, then do not give at all. Some patients are poor metabolizers, or some patients are taking CYP2D inhibitors along with this drug. So again, in these patients, we give only daily dosing. So do not shift them to BD dosing. Now coming to some landmark trials, what are the researches which are seen? So when Gemini study was done, in Gemini phase 3 study, uh, 327 patients were taken. These were patients with moderate to severe depression. Then they were divided into two groups, one with placebo and one with this molecule, and they were randomly distributed and they were studied for 4 to 6 weeks. It was a double blind dosing period study. So again, like we give day 1 to 3, they were given once daily, and then day 4 onwards they were shifted to BD dosing. And the same with some placebo drug was given, which was given once daily for 1 to 3 days and then BD thereafter. So as you can see, the green one is dextromethorphan-bupropion combination. The grey one is placebo. So the first circle which you can see, so on week 1 there is a sudden drop in MADRS score. So from week 1 there is a very low amount of depressive symptoms seen, and this low scores have been maintained throughout till week 6. And there was improvement seen in clinical global index scale also. So both these have shown improvement compared to placebo. Rapid and substantial improvement was seen. Significant improvement of more than 50% improvement in MADRS score. So the overall MADRS score was also less, and more than 50% improvement score in MADRS was also there. Then another study was the COMET study. This was a long-term study. By long-term means this were the patients were followed for 1 year. So total number of patients were 876. Out of these, 265 patients were rolled over, that is, they were previously on dextromethorphan and they were then included in the study. And 611 patients were there who were enrolled newly and given these molecules. So let's see what was seen in these study. So again, MADRS score was there. So week 1 improvement was seen in 8% of patients. Week 2, 22%. By week 6, 53% patients were there. By 2 months to 12 months, almost 60% improvement was there. And then again, the overall MADRS score was improved, but more than 50% improvement in MADRS score was also there. Week 1, 19%, and from second month to 12th month, almost 80% patient showed more than 50% improvement in MADRS score. Then again, the CGI score was also seen improvement week 1, 27%, but second to 12th month, almost 80 to 90% patients showed improvement in CGI scores also. Disability scale was also applied. As you can see, week 1, almost 43% patients showed improvement in disability, and around 70% was seen throughout the whole year improvement. So coming to the safety data, because whenever a new molecule comes, we are very concerned about the side effects which the patient are going to see. So the maximum side effect which was seen was dizziness. So dizziness was seen in 12% of patients. Nausea, again around 12%. Headache 8.8%. Dry mouth 7.1%. Decreased appetite 6.1%. So this safety data was seen in for the past 1 year. So in 1 year, all these side effects were found in the patients. Some of the warnings and precautions. So we know bupropion as a molecule. So the warning and precautions with that molecule will overlap, and dextromethorphan again. So clubbing both the warnings and precautions, we have suicidal behaviors, we have seizures, we have increased blood pressure and hypertension. Some patients might switch to mania. Sometimes psychosis might also be precipitated, angle closure, glaucoma, dizziness, serotonin syndrome, and in pregnant patients, embryo-fetal toxicity. So, what are the contraindications for this molecule? One is seizure disorder. If there is a prior history of bulimia or anorexia in patients, then again this molecule should be avoided because seizures are seen in these patients again. Abrupt discontinuation of alcohol, benzodiazepine, barbiturates and anti-epileptic drugs. If it is happening in the patient, then again better to avoid this molecule. We know if MAO inhibitors have been given, a washout period of 14 days is necessary to avoid any hypertensive crisis or serotonin syndrome. If the patient has known hypersensitivity to any of the components, then it should be avoided to avoid any Stevens-Johnson syndrome or anaphylactoid reactions. Again, whenever a new molecule is there, the most common questions are, can we give it in elderly patients? So there are no studies which have been done in patients above 65 years of age. So till 65 years of age, it can be given or it has been studied. So after 65, it is better to avoid. Again, because of dextromethorphan, abuse potential can be a concern for all of us. But studies which have been done, the 1 year study, it has shown that there is no abuse potential, and there was no drug seeking behavior also. So abuse potential is seen mostly in adolescents. So if you can avoid it in adolescent patients, it would be better. Then again, coming to the cardiac toxicity, or what is the cardiac profile, at maximum dose, that is the BD dose, there was no prolonging of QT interval seen. So no QT changes or no cardiac changes was also seen. So the salient features, it does not cause weight gain. It is the first and oral NMDA receptor antagonist. It is a novel mechanism of action. The mechanism of action is different from SSRIs, SNRIs, whatever which we are giving commonly. What they are seeing in research is that it has a rapid antidepressant efficacy. So what they're trying to say is that within week 1 only, improvement is seen in most patients, and the safety profile is also quite favorable. It gives clinicians a new mechanism of action, and it has a simplified dosing regime also. You give once a day for first 3 days, and then you shift to BD, and that is the maximum dose. So these were the salient features, and thank you so much for listening. I'll open this for discussion.